Thank you so much, everyone, for having us here this morning. Thank you for driving. Those of you who drove all that way, thank you for driving at all. I know it's kind of crummy weather outside, but we're really pleased to be here. And I want to invite you to ask questions as we go along. So I will invite people to participate at various points, but please feel free to stop me at any time. So before we talk about PTSD, which is a very specific type of response that can happen after people experience traumatic events. So we want to think about what is a traumatic event, what are normal responses to a trauma that most everybody will experience, and then how do we distinguish what most people would experience after a traumatic event from a post-traumatic stress disorder response. And I also wanted to address some very common misconceptions about PTSD. So there's a lot of stigma that still exists about what PTSD is and why people have it and how it becomes chronic. And some of those myths and misconceptions can really get in the way of people coming forward for treatment. So understanding sort of what keeps people stuck, what maintains PTSD over the long run is really important, because it's also what's going to inform what can we do if we are going to offer people treatment. So let's start with understanding what trauma is and what it's not. So like I said before, we, especially right now in our society, we hear a lot of use of the word trauma. So trauma is a very specific type of event. It can come in many forms. We can experience it in different ways, but we distinguish it from other types of distressing or upsetting events. So the kinds of events that we think of as being really traumatic won't surprise anyone. They're things like major accidents, natural disasters, physical assault, sexual assault, being involved in combat, either as a soldier, but also, as we're seeing right now, civilians can be exposed to combat, and that can be traumatic. Some of the things that we may not aim as often, race-based hate crimes are traumatic, and acts of terrorism. So there are lots of different kinds of events that can be traumatic. And we can experience these in different ways. So we might experience them directly. So we might live a traumatic event, or we might witness something happening to somebody else. And seeing that at close proximity, whether we know the person or not. But we can also be exposed to trauma in other ways that may not be as recognizable. So if someone that we're really close to has experienced one of these kinds of events, and they disclose to us, and we hear about, the graphic details of these events, and we feel their distress and we care for them, that can be a route for trauma exposure as well. One of the other things to consider is that some people in some professions may be exposed to trauma as part of the work that they do. So thinking about police officers, other frontline workers, thinking about ourselves, we sometimes hear about trauma repeatedly through the course of doing our work. And that can be a route of mechanism to trauma exposure as well. And one of the things that people often wonder about, especially in times like we're experiencing right now, is what can be the impact if we're repeatedly exposed to these kinds of events, if we see them on television, if there's chronic news coverage, and just seeing people in distress and dying or killed all over the world. Can this be traumatic to someone? And this is very upsetting to anyone who's watching or witnessing these events take place. Typically, we think about these kinds of events being traumatic if we have a really personal connection to somebody who's involved in the event. So if we know someone who is in one of these combat zones or war zones, and we have that personal connection, seeing coverage of these kinds of things, even if we're far away, can be traumatic. We don't necessarily, it may not be traumatic for everyone. So if we don't have a personal connection, we may not think of it as traumatic per se, but that doesn't diminish the fact that it's incredibly upsetting and distressing. And so we don't want to minimize other kinds of events that we can react to, that we can have strong emotional responses to, things like bullying, harassment, very difficult work circumstances, stresses at home, in parenting or marriage or financial stresses. All of these kinds of things are naturally very upsetting, very distressing, but we do distinguish them from traumas. And that's because traumas seem to impact people in very specific ways. And that's part of what we'll go on to talk about a little bit later. So it's important to know that those kinds of traumas that we talked about before can happen to anyone. So trauma, unfortunately, doesn't discriminate. We see that it happens across cultures, across genders, across different kinds of populations. We know that it's more common in some places than others. For example, in countries where there's high rates of conflict, of course, people have more exposure to trauma, but trauma seems to happen across all cultures. And when we talk about PTSD, that kind of human response to trauma also seems to be fairly common across cultures, in the sense that people react to trauma in very similar ways. And it's very common. So unfortunately, many people will experience at least one of these kinds of events over the course of our lives. So it's really important to be mindful of the prevalence of that. We'll come back to that in a moment. So because it's so common, it's also really important to understand all of the ways that trauma can impact us. And it can be really a whole range of responses that people can experience in the days and weeks that follow. And you're going to hear us talking throughout the presentation about the impact on the way that we think. So our cognition, our mental processes, our emotions, and our behaviors, so our coping responses. We kind of think about our responses falling in those three categories. So for anyone who experiences any of those kinds of traumatic events, from a cognitive perspective, we tend to be very preoccupied by what happened. So thoughts about the event that we experienced, how we're responding to it, the immediate aftermath tend to dominate our thought processes. We can have memories about what happened seem to come out of the blue when we don't want to have them, and they're very upsetting. We might have bad dreams, our sleep might be disrupted, and we might feel really intensely upset or distressed if something reminds us of what we experienced. And these can sometimes be things that are otherwise benign. It might be seeing something on a television show that triggers a memory of something that we've experienced, and that might not have been something that we reacted to strongly before, but it's taken on a new meaning because of the traumatic event. So there's definitely an impact on people's thought processes after a trauma, and this is for most people. And then because that's very upsetting, because it's very distressing to have almost feel like these thoughts are taking over. I don't feel like I'm in control of whether I'm experiencing these memories or not. It's often the case that people develop really understandable coping responses to those kinds of thoughts. So often, as a way of coping, people may start to avoid. So that can be, avoiding going out, avoiding situations or people or places where I think that I might be at risk of something happening again, or where I might be reminded of what happened. I might withdraw from normal activities, or people might start using other coping responses. So another very common thing after any kind of trauma is that sometimes we would see alcohol or substance use increase. And so these are really what we're understanding is just ways that people are trying to get by because of the distress that's associated with all of this. And then emotionally, there can be really intense emotional reactions following traumas. So we tend to think about fear as a response to trauma. So if I'm in a major accident, of course, there might be a response of fear, but oftentimes different kinds of traumas can involve a whole range of emotional responses. So yes, absolutely, fear can be part of it, but it can also be anger, intense guilt, shame, grief, sadness, Some people feel an absence of emotion. So as I used to have a whole range of emotional responses, it might feel like I'm numbed out after a trauma. And so all of these things are really normal responses. And most people will experience, several of those kinds of responses after a trauma. That doesn't discriminate between people. So it's kind of an indication that something very significant has happened, something that's out of the ordinary, something that doesn't fit with our worldview or expectations. And these symptoms that we're experiencing are signs that we're really struggling to come to terms with what has happened. It's dominating our thoughts. We're trying to push things away to make sure that we don't experience this again. So all of these things can be thought of as really normal ways of responding to trauma. One of the other things that we were talking about before is that these kinds of experiences are very, very common. So there's a couple of patterns that we see hold across all of the research studies that are done. So the two things that are fairly constant are there's a very high rate of trauma experiences in our general population. Estimates vary from study to study, but generally speaking, some of the lower estimates are around 50% of us will experience at least one trauma over the course of our lives. So think about us in this room and what 50% of us represents. And that varies up to, we've seen estimates up to 3/4 of people might experience a traumatic event. And it might depend on the kinds of traumas and where you live and these kinds of things. But what we know is that this is not an uncommon experience. The other factor that we see pretty consistently is that despite the really high rate of exposure to trauma, the development of PTSD after trauma is relatively lower. So we see that there's a gap. And estimates vary, again, depending on the study, but somewhere around 8 to 10% of people who experience a trauma will go on to develop PTSD. And that gap tells us something interesting. So one of the things that it starts to make us wonder is what is what's going on for people who experience a trauma and somehow recover from it, as opposed to folks who might experience the same kinds of traumas and go on to develop a PTSD response. And so researchers have actually followed people over time to try to answer those questions, right? To wonder, what's going on for some folks. Any thoughts as to what might account for that difference? Why, Angela?
Some people have better supports or people around them.
Yes. Yeah. Hold that thought. We're going to come back to that. That's a huge factor that can be protective after a trauma. So a trauma is a trauma. There's no undoing it, but having access to strong social supports afterwards is one of the really strong factors that seems to help people recover. And then the absence of that seems to be a factor that places people really at risk. So when I say hold that, I want to come back to that idea because we want to talk a little bit about why that is. Like, what is it about the social support that's really helping people to recover? Because that's going to tell us a little bit about what we may need to provide in our treatments as well. Any other thoughts as to what might be going on for some folks versus others? Yes?
Their environment.
Their environment. Do you mind saying more?
Where they are in life. So if they are in an environment that is going to trigger their trauma, or for the folks that have those triggers but take themselves out of that environment.
Exactly. Yes. So for anyone, the first part of what you said, for anyone, one of the reasons that PTSD is so difficult to experience is that there can be triggers anywhere. So really benign things can come to be triggers after exposure to a trauma. But the second part of what you said around people who are exposed to triggers but change their environment seems to be one of the key ingredients. So we know that it's very normal after a traumatic event to pull back and avoid. And who wouldn't, in fact, right? Because for anyone, it's an extremely upsetting experience, and none of us would want to experience that again. So 90% of people will start to avoid and withdraw. But for some people, like you said, that avoidance can take hold. So think about a very straightforward example. If I have a car accident, which I have had. So in the immediate aftermath of having a car accident, I might think, I don't want to experience that again. Of course, no one would. That was very scary. I felt like I was at risk. And a natural response would be, maybe I shouldn't drive as much, which makes a lot of sense. And in the short term, if I don't drive, if I start taking public transit, or if I ask my partner to drive places, or if I stop going places that require me to drive, it might let me feel safe. So in the moment, I'm feeling like this is allowing me to avoid this risk again. And that makes a lot of sense. In the long run, that might not be helpful, because what could happen if I continue to avoid driving?
Your life changes. You're not able to go where you want to go.
Right. So it robs us of things. It starts to, the avoidance that's designed to help me feel better starts to now rob me of things that were important to me, and I can start to feel worse. So it can actually worsen the distress. In addition to that, if I stop driving on the highway and I stop going places and I only go places if I absolutely need to and have my partner drive, and I don't have an accident, it might reinforce the idea that I'm not having an accident because I'm not driving. And it keeps that cycle going. I don't have the opportunity to learn that accidents can happen. We know that they do, but that they're relatively uncommon, right? Which is kind of what we all take for granted when we go out and sort of do these things on a daily basis, is that there's no zero risk activities, but on the whole, many of the activities that we do are relatively safe. So that sort of ongoing avoidance seems to be a really key ingredient in what keeps people stuck in the very same symptoms that most people have after a trauma. So we can come back to what we said Angela earlier about how do some people get stuck in that pattern of avoidance and others don't. And like you said, the second really important factor is whether people have access to good social support. So we want to think about what can happen on the other hand. So we see what happens when some people are able to recover naturally over time, right? They start to gradually do things that they used to be doing, sort of get back into old habits and regain their lives. For others, there are things that they might be doing in service of protecting themselves against further trauma, or in service of feeling safe, feeling better, that might unintentionally keep them stuck. This is not the intention. So these are the kinds of things. So we've talked about avoidance already, and here we're talking about avoidance that persists over time. So after a car accident, I may not drive for a few weeks, and that might be absolutely fine. But if I stop driving for months and years, that's when that ongoing avoidance starts to become problematic and starts to have other kinds of consequences as well. Some people may not avoid altogether, though. So one of the things that we'll come back to talking about later is I may still go out driving, but I might do so in a very specific way. So I might only drive if my partner is in the passenger seat, if it's daylight out, only on side roads, these kinds of things. So am I avoiding driving? No, but I'm using what we call safety behaviors. So these are things that if I go and do an activity that feels really risky, there's things that I lean on, I depend on to make me feel like I'm mitigating my risk. And sometimes folks can become accustomed to using those safety behaviors. And then that's also something that might interrupt learning that this is relatively safe. Like I can drive even if I don't have my partner in the car, for example. We want to think about suppressing thoughts and memories. So again, no one wants to think about upsetting memories. So we do tend to push those away. If we do that chronically, so if we find ways to keep our thoughts and memories away from us, that seems to keep people stuck as well. Any sense of why that might be?
Because they're not processing what they've been through.
Yeah, exactly. So that processing is also sort of one of the natural ways that we heal when something really upsetting happens. And it doesn't need to be just, major traumatic events. It seems to be the way that we kind of heal as humans, generally speaking. But it does, if we keep pushing away, emotions and thoughts and memories, it does seem to interrupt that natural kind of processing of what's happened and coming to terms with, so that I can move forward. Distraction is another thing that we see a lot. And again, there's nothing inherently wrong with any of these things. A good distraction is absolutely fine. We all use distraction at times. We all use avoidance at times. But these are when these habits become chronic. So how do you think people might be distracting themselves? Have you noticed anything? Even in the clients that you work with, ways of distracting?
I know he's constantly on his iPad.
Yes.
Like almost not even there, just scrolling.
Right. Exactly. So for those of you that may not have heard, I'll just repeat it for the recording, is constantly being on your iPad or your computer. Distractions are really readily available these days, right? I have a teenager, distractions are everywhere. Yeah. So yeah, we do see a lot of people sort of not using it for a purpose, but sort of keeping their mind busy. So that can be scrolling through your phone, using the internet, television or movies, video games, absolutely. Some people keep really, really busy with work, or doesn't have to be work for pay. It could be work at home as well. Just finding ways to crowd something out of our minds, right? I'm gonna think about something else so that I don't have to think about this. So that's something that we're mindful of as well. Again, naturally, it's called vigilance, but it's essentially just being really watchful for potential signs of danger. I've experienced if something awful, it's natural to kind of keep track of what might signal to me that this could happen again. So if I experienced an assault in a really crowded place, if I go into crowds again, I might be scanning my environment, looking at what people look like, looking for signs of risk. So that I'm, again, trying to protect myself from this happening again, but I might become accustomed to scanning in this way and not feel safe if I can't check all around me, right? I might sit with my back to the wall instead of having my back facing the door. Again, alcohol or medication use, again, use in moderation, no problem. But when it becomes sort of functionally related in the sense of I'm having a drink or I'm taking a substance specifically to stop myself from thinking about this, that's when I want to pay attention to those things. And then giving up enjoyable activities. So it can just be with avoidance happens out of fear. So I'm afraid that something is going to happen, so I'm not going to do it. It can also be withdrawal and loss of interest. So I just don't have, the same sense of joy in doing these things anymore. So I think I'm just going to stay home and natural. But, as we were talking about before, that starts to sort of have other side effects as well. So some people learn these kinds of coping habits only after a trauma. So it's like we're doing what we need to do to get by. But for other people, these might have been coping habits that predated a trauma. So these might have been things that were learned in childhood. In our society, there are lots of expectations around, is it okay to express emotions and how do we express emotions? So it's not uncommon for us to hear, like I was told during childhood, that boys don't cry, or whatever the messages are that can persist across time in society. So some people might have been given messages like that early on in life, or they might work in environments where doesn't feel okay or safe to express emotions or to acknowledge that we're hurting. So we might be encouraged to, use other ways of coping to distract ourselves. And some people receive these messages without ill intent. People who love us might not want us to feel that distress. So we may be encouraged to think about something else or, use distractions, things like that. So those are things that we're looking for in terms of ways that we cope after a trauma that might unintentionally get us stuck. But there's also some things about the trauma itself that might be risk factors as well. And we started to talk about this a little bit earlier. So generally speaking, we can think about things that happened before, during, and after a trauma that might put people at higher risk than others. And you'll see here that on your left side, these are sort of weaker risk factors, and they progress to being sort of stronger predictors of who might develop a PTSD response as we get closer and closer to the trauma itself. And so some of those risk factors that yes, are risks, but are a little bit weaker, are sort of static historical factors. So basically things that we can't do anything about. And also things that, if you think about them, are probably predictors for many types of distress or difficulties with adjustment, not just PTSD. So these are things like having a family history of mental illness. Again, so we know that this predisposes people not just to PTSD, but to other kinds of anxiety, depression, etc. But having a family history is a risk factor. Previous traumatic events. So we were saying before, it's not uncommon for people to experience a trauma during their lives. It's also very common for people to experience more than one trauma. And so for people who've experienced a previous trauma, if we go on to experience another one, that understandably places us at higher risk of developing PTSD. We might be in a situation where now, if I was thinking about something, if this started to shift my beliefs, having another trauma might just confirm, that the world is not a safe place, for example. And then in addition to a family history of mental health difficulties, our own pre-existing history as well. So if we've had experiences with depression or anxiety or other difficulties with adjustment or difficulties with emotion regulation, that can place people at risk. And kind of as a group of risk factors, these kinds of things might be risks because they might affect the way that people cope following a traumatic event. So if I'm struggling already with emotions before a trauma, then it might be additionally difficult for me to cope adaptively following a traumatic event. Okay. But that doesn't seem to be quite as important as the factors that might happen during, or especially the factors that happen right after a trauma. So there are some, any type of trauma can lead to PTSD. There are some types of trauma that are more likely to lead to PTSD than others. And it seems to be because of these certain factors about the trauma itself. So the degree of risk to one's life or risk to life in general seems to be a factor. So we can think about this as it's not a perfect indication, but the severity of a traumatic event. So sexual assault is among the kinds of traumatic events that's most likely to lead to a PTSD response, but not for everyone. The intensity of the emotions that somebody experiences during the traumatic event. So how severe is the person's response can be a predictor. And experiencing dissociation. So dissociation is a temporary sense of being disconnected from ourselves or our world, the world around us. So people might describe feeling like I'm almost like watching myself experiencing this. So depersonalization or derealization, a sense that things around me feel really unreal or like I'm disconnected from them. There might be some dissociative amnesia, like difficulty recalling, personal events that happen around the time of the trauma. And again, it's not completely predictive, but it can increase risk for PTSD. Okay. And then most important is, as you said before, what happens after a traumatic event. So for anyone, this is going to be something that's really difficult to deal with. But if after a trauma, I'm having difficulty and I also don't feel like there's anyone that I can turn to, like no one who might understand what I've experienced, no one that I can lean on, then I'm processing this experience on my own. And that lack of social support is a really important risk factor. So it's starting to tell us like what people might need after a trauma in order to heal, which makes a lot of sense. We heal in relation to other people, in relation to people who care about us. And it doesn't necessarily mean like an absolute lack of social support. I might have people around me who care about me, who may want to help me, but if I perceive that I can't reach out, or if there's something that's blocking me, even a perceived lack of social support is really important, because that's the thing that might stop me from telling someone that I'm hurting. And yes.
Oh, I just wanted to ask, so you said as someone who experienced multiple traumas and experience more like the experience PTSD, would you say the same for then someone who's gone through PTSD and other traumatic event then like PTSD for a different type of trauma?
That's a really interesting question. So for those, and I'll repeat it if it's okay through Zoom. So the question was, if multiple traumatic events, increase the risk for developing PTSD, what if somebody is already experiencing PTSD, if I've got that right, and then experience another trauma? Yeah. So I would say that there's two ways of answering that question. So one is if somebody already has PTSD, one of the things that we know is that on the one hand, there's really excellent treatments for PTSD that help people to recover, but that when someone doesn't have access to treatments, PTSD tends to be very chronic and doesn't tend to just remit on its own. And so if somebody already has PTSD and re-experiences another trauma, it will be very likely we would expect that person to have, to continue with symptoms or possibly have an exacerbation, like an increase in symptoms. On the other hand, we have seen that when someone can access treatment for PTSD and resolve those symptoms, which doesn't mean forgetting about the event, but, move beyond intrusions and avoidance, that people sometimes do re-experience another trauma after getting well. And, if we can help somebody not just resolve the past trauma, but also, learn to not avoid and to be able to process things, that can be protective against the future development of another episode of PTSD. If that did that answer your question?
Yeah.
Yeah. Okay. Yeah. So we really want people to get access to treatment if possible. Any other questions about that? Yes, Connie.
I was wondering, is it the strategies that they can carry over to the next episode? Like, does there seem to be a recall of, oh, this is how I managed it myself, I carry over?
Right. Great question. So yes, so when we're working with someone doing trauma processing, which I'm going to talk a little bit more about later, what we're trying to do is to help them to do what they didn't get a chance to do in the immediate aftermath, right? So we're harnessing some of what we know about how do people recover naturally. And one of the things that we do is to help people, process the trauma and experience the emotions, bring them to the surface rather than pushing them back. And what we hope happens at the end of that is not just that they've been able to come to terms with what has happened in the past, but also that, going forward, they're carrying those habits into the future. So if something bad happens, they can remember, I need to start getting back into some of these things and not continue to avoid. That's what we hope is going to happen. We talked about lack of social support, can be emotional, like we talked about. It can be other kinds of support. So some people need financial supports, legal supports. They might need medical supports, and if they feel like they're lacking access to those things, that can be impactful as well. Life stressors. So if I experience this awful event and I'm already in a situation where my cup is very full, I have stress at home, stress at work, financial stresses, whatever they might be. Just the idea that my ability to cope with something new and significant is probably diminished relative to somebody who doesn't experience as many stressors. So we want to think about how that might impact equity deserving populations who may be more likely to experience a lot of psychosocial stress. And then the severity of early symptoms. So we talked earlier about how most people experience symptoms after a traumatic event. The people who experienced the highest severity of symptoms in the early phases is a risk factor for ongoing feelings of being stuck. So now this is going to start to look familiar. So now we're talking about individuals who've experienced trauma and who do go on to develop PTSD. So we want to start to talk about if those are all natural responses to a trauma, and that's how people can kind of get stuck in continuing to experience these things. What is post-traumatic stress disorder? So PTSD is a psychiatric diagnosis, and it basically has 4 kind of clusters of symptoms. So the first cluster we call intrusions, and that is, and it's going to sound familiar, basically ways that the trauma intrudes into our consciousness when we don't want it to. So people are going to have intrusive thoughts or memories that feel like they're not within their own control. So I'm not thinking about this intentionally. They might have chronic nightmares, and it doesn't necessarily have to be about the trauma itself. It can be sort of the theme of danger or risk, for example. Some people have flashbacks where it feels like this isn't just a really bad, vivid memory. It actually feels like I'm no longer, in my current surroundings. It feels like I'm right back there. Or having really frequent, intense emotional reactions or even physiological reactions to anything that might remind us of this. Second cluster of symptoms is avoidance. So again, that same early initial avoidance that most people experience, this is when we're getting stuck in this pattern. So we're avoiding things external to us, people, places, situations that remind us of what happened, where I might be at risk again, but we're also avoiding things that might be internal to us. So my own thoughts, my own emotions, my memories. The third cluster of symptoms is what we call cognition and mood. So how does trauma impact the way that I think, the way that I feel? Right? And so oftentimes when people have PTSD, they feel really badly about themselves. So there's a lot of self-blame. They carry a lot of guilt, shame, but it also can impact the way that we see other people, particularly when people have an interpersonal trauma. So if this is something that was perpetrated, like an assault, for example, it might be very understandably very difficult to trust other people. So not just the person who was the perpetrator, but it might be difficult for me to trust anybody. It might be an altered sense of safety in general. So it's hard for me to feel safe anywhere, for example. And then the last cluster of symptoms is what's called arousal symptoms. So this is where someone feels like they're constantly in a high state of alert. So people might be really unusually irritable, like I'm having fights with my kids or my partner that is atypical for me. Sleep disruptions, constant physical tension. This is where the arousal symptoms, where that hypervigilance fits in. So always being scanning and on guard. And because those symptoms are so upsetting, again, it's understandable that people avoid. And then all of this starts to impact other areas of life as well. So if I'm constantly preoccupied and I'm avoiding things and I'm irritable, and this is going to start to impact relationships, maybe my ability to go to work or be productive at work, to see people, to do my activities. So it starts to have a bit of almost like a bit of an oil spill effect, where it's not just the symptoms themselves, but the impact of the symptoms too. Okay. So you probably recognize a lot of those as the normal reactions to trauma. So these are some of the indicators that we use to determine, is somebody having an understandable reaction to something that they've just experienced, or are we thinking, that this might be an individual who's experiencing more chronic symptoms? So these are some of the indicators that we use to distinguish that. So duration. because these symptoms are normal, we only want to think about whether PTSD is present after about a month. Right? So we don't want to discount people who are in distress, a lot of distress really early on, but we want to allow time for people to experience those symptoms and have a natural recovery. So a month is usually the threshold. Mind you, we usually see people far after the 1 month mark. So people tend to come forward for treatment sometimes many years after the development of PTSD. We want to think about the severity of the symptoms too. So these are typically, in the case of PTSD, symptoms that are very severe, very frequent, and the impairment that's associated with the symptoms. So again, it's not just that I'm having intrusions that I'm avoiding, but also that this is starting to rob me of things in my life, school, work, friends, hobbies, ways that I coped before, these kinds of things. And it's also associated with, more of a need to utilize the medical system, the mental health system. So it has pretty wide-ranging effects. And we also know that PTSD is very uncommon to come on its own. So because of the ways that it impacts people, it's often associated with experience of other conditions as well. So for example, substance use and alcohol use are higher in individuals with PTSD. And again, if you think about the arousal that people experience, like always feeling tense, always having, strong physiological reactions to reminders. Sometimes if they're using alcohol or substances, it's an effort to sort of tamp those down, keep them at bay. So that is a very frequent association. These are old data, but these patterns hold. Depression is very commonly seen in individuals with PTSD. It's hard for someone not to have their mood impacted if they're needing to avoid a bunch of activities that they were able to do before, if they're experiencing a lot of loss of interest and withdrawal, if their relationships are disrupted. So again, very common. See, we've got panic disorder and agoraphobia here, but generally other anxiety disorders are highly co-occurring with PTSD as well. And there seems to be a really significant relationship between PTSD and the experience of medical, like physical illnesses as well, across a whole range of physical illnesses. And there might be various reasons for that. So all of this to say, PTSD is hardly ever very straightforward, right? It creates a significant impact in people's lives. And wanted to come back to some of the myths and the stigma about PTSD, because you can see that it's very impactful, very damaging, but there's also a significant amount of stigma that often keeps people from coming forward to treatment. So one of the most common things that we hear in clinical practice is that, PTSD is a lifelong illness. People might be coming to treatment thinking, I would like to just find a way to manage these symptoms, almost like a belief that I'm going to need to live with these intrusions and with this avoidance forever. So there's a lot of research to suggest that we have very effective treatments for PTSD, and that if people can get access to effective treatment, recovery can happen. It doesn't mean, like I said before, it doesn't mean I'm going to forget about what happened. What we're looking for is to move forward with this as an experience that I've had. It's an awful experience. It will continue to always be an awful experience, but that I'm moving forward, having come to terms with the fact that this happened and reducing the symptoms of intrusions, avoidance, arousal, etc. And another really damaging misconception is that PTSD is somehow means something about the person. It means that I wasn't tough enough to take it. It means that I'm weak, or there's something wrong with things that we hear a lot. And if we think back to what are some of the risk factors, none of them have to do with what kind of a person I am, what kind of a character, what's my personality, right? These are things that are, natural coping responses that people are leaning on, factors about the environment, other risk factors, and PTSD can happen to anyone. So what really does maintain PTSD, and this is just a recap of what we saw before, is some of those coping responses that people are using. So because the trauma memory is upsetting, because I may start to think things, negative things about myself, it makes it feel for a person that the risk wasn't just then, that there's always a sense of current risk. And because there's a sense of current risk all the time, I'm going to start to use some of those coping responses that we talked about. So I'm going to start to avoid, and I'm going to start to withdraw, use substances, etc. And so if we know that those are the things that keep PTSD going, then that gives us a clue to what we need to do for treatment, right? So we're not targeting the trauma itself. We can't do anything about that. Our targets for treatment are this bottom line right there. So what are the strategies that people are using that are keeping them stuck? So this is a very, very short primer on treatments for PTSD, but just highlighting what are some of the key ingredients. So just like in medicine, in physical healthcare, there are like first line treatments. So if I were to go for treatment for cancer, I would be offered whatever are the first line chemotherapies or surgeries or what have you. There are first line treatments for mental health conditions as well. And so right now for PTSD, the first line treatments are the cognitive behavioral therapies. So there are different techniques, different therapies under that CBT umbrella, but they all share some common features. So you might hear about things like prolonged exposure, cognitive processing therapy. Some of you may have heard about EMDR. So I can briefly describe those later, if that's of interest, but I really wanted to focus on like, what are the common elements of that? So all of those therapies have different strategies to get at the same underlying thing. So all of them are promoting some sort of safe confrontation with trauma memories or with trauma reminders or people or places or situations. So basically they're encouraging people to reverse the habit of avoiding, right? So instead of avoiding, we're, validating why that might happen, but we're encouraging people to slowly get back into their lives. And the reason is so that people can have that kind of corrective experience, so that, if I'm not sort of experiencing this in the immediate aftermath of a trauma, I'm taking this opportunity later on to learn that some of what I've come to fear as a result of these awful events is actually less threatening than I might take it to be right now. So those are some of the common elements of PTSD treatment. And I want to leave it off for there because what we're going to do later is Melissa will come back to some of those key elements and talk about how do we use and understand those if we're working with people who have PTSD who are in treatment, or if we're working with people with PTSD who are not yet in treatment. So what can we do? But before we do that, I'm going to turn it over to Dr. Gosselin, who will talk to us about the intersection of PTSD and acquired brain injury.
So now that you know so much about PTSD, we're going to talk about the intersection of both, because your clients are, my understanding, all of you is people who suffer an acquired brain injury. And so how do you recognize in people with acquired brain injury what to do, what happens? So we're going to talk about that, the acquired brain injury, and also the intersection of acquired brain injury and PTSD. So many of the contexts in which an acquired brain injury occurs may also be psychologically traumatic, obviously. Think of a car accident, war, like our veterans, like often they have they'll have a blast, but they're also, the whole situation was super traumatic. They lost friends, or a car accident, you hit the head. But then also you have all the psychological trauma of the actual car accident, like Dr. Todd was talking about. You can also have a pre-existing PTSD condition in somebody with who acquired a brain injury. or something that happens after the acquired brain injury, because they're more at risk of things happening as a result of all the effect of the acquired brain injury. So, as you know more than I do, you have multiple causes of acquired brain injury. And also there is a degree of impairment that varies from one person to another. So just tell me, just so I know a little bit, who do you see most? Who's your population like in terms of like, so we have so many causes of acquired brain injury, tumors, trauma, it could be Alzheimer's. All these are like under the big umbrella of acquired brain injury. Alcohol can create an acquired brain injury, or other like toxins, hypoxia, a stroke. So who's most frequent, like the prevalence of who you see typically? Stroke. Oh yeah, yeah.
We use most of our clients of the day program are trauma, and our young ones are tumors.
Oh, okay. So you have the young ones too.
That's for our male, and our females are strokes.
Strokes. So lots of strokes. Traumatic brain injury, not as much.
I think most of they're stemming from traumatic, but then because of their brain injury, they kind of also fall into subsequent spaces as well, such as hypoxia, stroke,
Alcohol,
seizure.
seizures, yeah, seizures from stroke often. Okay.
But there's been an uptick in
Really? Okay. All right. Oh, right. Of course. Yeah. 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 Tumors, eh? Cancers. Okay. So I imagine the hypoxic is after a overdose,
Yeah.
right?
After that or
Cardiac events. Okay. So oh, I just want to say the slides might be, my slides might be a little changed a little bit from when I send it to you. So it's mostly the order, they're all there, but I changed the order a little bit, but it's all there. So don't be surprised. So this is just to highlight that, of course, as we said, the acquired brain injuries can be from multiple different areas. Some are non-traumatic and some are traumatic. Among the traumatic, you have the open type of brain injury, so where like a surgery is an open brain injury. Also any penetrating wounds where like literally blood coming out, and the closed brain injury is like you have the hidden but no blood. So statistically, this is from the US. It seems not necessarily representative for you. You seem to have much more of the strokes, and it's probably how people refer to you. Statistically, the traumatic brain injury, you see, basically it's just to highlight that about 2/3 of the acquired brain injuries fall under the traumatic brain injury. So any type of like car accidents, being struck by somebody, so an assault, motor, like the falls, a lot of falls from lad. Oh yeah.
Number one in Ontario, but
Yeah.
we don't see as many are elderly.
Okay. Are they sent elsewhere maybe too?
They just go into the
Okay. Okay. So because of the prevalence and because of the research, I'm going to focus a little more on the traumatic brain injury, and you'll see why too. But I think what we're going to talk about today can absolutely apply to any type of brain injury. But we know more from traumatic brain injury for a few reasons. Because first, TBI is the most prevalent as we saw. So the traumatic brain injury is about 2/3. Also the phenomenon that for other acquired brain injuries, it's so heterogeneous. So cancer, it will have a different impact than anoxia, for example. So it's so much more harder to study. And also like a tumor, depending on the area of the brain, will have a different effect clinically. So it's so much harder to study the impact. So just keep in mind most of the research. Do you hear me okay? Yeah, okay, good. Most of the research per se has been done with people who suffered traumatic brain injury. There was another phenomenon as we had the Iraq and the Afghanistan war. So a lot of the studies came from the US and Canada as well, from our veterans who suffered traumatic brain injuries. And of course, we're talking about traumatic brain injury and PTSD. So I tell you, this population, it was a good population to study the dual diagnosis phenomenon. So just you're aware a bit of the statistics. So this is just to talk about Ontario. So just to say ABI is very, very prevalent and much more than we think, really, especially for the younger, apparently. Main cause of death for younger than 40 years old, and the most prevalent among the 18 to 64 years old. So definitely in a great deal of support. So we're very thankful in Ontario to have you guys taking care of them. So I'm a neuropsychologist, so I'm interested in the brain, and with any acquired brain injuries, it's very, very brain related. So we'll talk about the brain a little bit. So this is, you might have probably, feel free to jump in and ask questions, by the way, if you have any, but this is just to highlight that, okay, we're talking about a big umbrella, acquired brain injury. The area of the brain that is impacted by the injury will impact a lot the way your client behave in front of you. So there will be much different presentation depending on where the injury is. So also some acquired brain injury have diffuse effect on the entire brain, and other brain injuries have local effects. So if you are in a car accident and you hit your right temporal lobe, you'll see effects that are very different than if you have suffered from anoxia, which will have a very diffuse effect throughout the brain. So any questions about that? That makes sense. So this is just to highlight that what you can expect, the different. So sometimes if you have a client in front of you with weird symptoms, for example, of I think that probably happens a lot, irritability, lack of focus, some language difficulties. Maybe you can suspect, oh, they must have something happening more in the frontal area, the prefrontal area of the cortex. When somebody has an area that has been impacted that is more parietal, you'll have a very different presentation with difficulty reading, spatial misperceptions. So sometimes you might see very weird symptoms, very weird clinical presentation that that digress from what you see with your other clients, and it might have to do with where the injury is. So it could be a tumor. If it's in parietal, it's going to present very differently than if it's in the prefrontal area, for example. So occipital area, you'll have visual problems, so blind spots. It's not blindness per se, but the vision can be blurred, and they will have like bizarre experience with their vision. The temporal lobe is problem with short and long-term memory. There could be some difficulty with language. You will see that a lot in strokes, because with the strokes, folks often you'll have a stroke in the temporal area. So you'll see Broca's aphasia or Wernicke's aphasia. So there will be marked language difficulties, especially if it's on the right side. If it's the cerebellum, which is in the back here, there will be more difficulty walking, slurred speech, difficulty with balance. And the brainstem, it's rare that you see brainstem strokes, because usually you die from that, because it's a very center place. So this is where the breathing center are, the sleep-wake regulations. So if there is a minor stroke there, you might see somebody with difficulty swallowing, change in breathing, things like that. So that gives you some information where the damage is in the brain. Usually, you'll see a lot of people with the prefrontal cortex syndromes. Prefrontal cortex is super large, it's half of your brain, so it's easily impacted. The frontal aspect is where the higher functioning is, so this is often, you'll see difficulty with problem solving, initiation. There's a lot of apathy, perseveration, so repeating the same things and the same mistakes over and over again, despite the fact that it doesn't work. Social skills have damaged. They don't know anymore how to socially relate. Lack of insight, so they don't realize that they have problems. They think they're fine, So, you ring a bell? Yeah, you see that in your people. Yeah. So another thing to keep in mind, the severity of the trauma. So that will impact. So you have people with stroke who have small stroke, people with stroke who have massive strokes, people with head trauma who it was very mild. So for the traumatic brain injuries, the mild ones, this is more the assessment of traumatic brain injury. So when there's literally a hit to the head, there's ways to measure the impact of it. So if basically it was the person confused and disoriented after the trauma, was there any loss of consciousness? Is there post-traumatic amnesia? So the post-traumatic amnesia is after the head trauma. There's a period where the person doesn't remember anything after the trauma. So it can last for a couple of minutes, it can last for 24 hours, and it can be full-blown coma, which then, of course, you remember nothing. So the severity of this will impact, of course, the severity of the clinical presentation and the recovery after the trauma. So what are the long-term brain injury symptoms? You'll see that a lot. So you have like clusters. There's physical symptoms that are because of the changes that happen in the brain and the connections of the brain. You'll have like the physical symptoms like headaches, but you'll also have like the memory problems, basic movement problems, the difficulty processing information, and also you'll have some psychiatric symptoms. I'll talk more about that. PTSD sometimes, also depression. Depression is super prevalent among people with acquired brain injuries. So you must see that a lot. So it's much more prevalent, in fact. So that's an exhaustive list of what you can see in terms of physical and medical symptoms versus cognitive symptoms versus emotional and behavioral symptoms. It's rare you're going to see all the symptoms in one person. So sometimes you'll have a client with fine and gross motor skills difficulties, a seizure disorder, the endurance, sleep disturbance that would fall under the physical and medical problems. Then you'll have the cognitive problems. So the cognitive and emotional problems are probably what sometimes you scratch your head on how to help those guys and those women, you know, because it's like, what do we do, right? It's like when there's a lot of cognitive problems from the ABIs. So information processing. Some people have difficulty orienting to people, they, you know, to space and time. Things are blurred. Their memory planning for you guys, like, you know, their planning and organization is so hard. This is why they need your help, really, usually. So I would say most of the time you'll probably see that in your clients. Communication problems. Also emotional, you'll have the depression, a lot of anxiety, aggression, they're irritable with you, they don't want to take direction very easily, you know, so you can recognize changes in personality is very frequent too. So if you know the family or the people who were there in their life before they acquired brain injury, they'll say, oh my God, the person is so different, it changed a lot. So, so the psychiatric disorders in general, so the ABIs increase risk for psychiatric illnesses, of course, including PTSD, mood and anxiety, substance abuse too, and psychosis sometimes is very rare, but it happens. You'll see psychosis that is subsequent to the acquired brain injury. That complicates the picture quite a bit for you guys. And depression being the most prevalent. Also, anxiety disorders frequently coexist with depression. So you might have people with generalized anxiety disorders, or panic attacks, obsessive compulsive disorders. In recent years, what we've studied the most, mainly because of our Iraq and Afghanistan guys, but also because we realize it's a big problem, is the PTSD in the context of traumatic brain injury specifically. And among traumatic brain injuries, the mild ones, so the less severe ones, are by far the most prevalent as well, about 75%. That's interesting for you to keep in mind. This slide, I'm just going to explain it a bit. So what you see in gray is a traumatic brain injury cohort. So people who had the head trauma, and in orange, it's the non-traumatic brain injury. So all the other acquired brain injuries. This is one of the few research that was discussing this. So your strokes people, the anoxia, the tumors. So this slide just highlight that with traumatic brain injuries, the comorbidities that are the most prevalent are PTSD, other anxiety disorders, depression, alcohol dependence. With the other type of acquired brain injury, this is less frequent. What you have more, which makes sense, is more the medical condition. So diabetes, hypercholesterolemia, because that's probably what led to the stroke, for example. And stroke is by far the most common acquired brain injury that is not traumatic. The tumors are not that prevalent, but very terrible when and also keep in mind that depression is very prevalent. So you and also in the non-traumatic brain injuries, Whereas your PTSD, and in this cohort anyways, was relatively less frequent than for the traumatic brain injury. Make sense? Any questions on that? So complicating the pictures with your patients are the fact that the symptoms from traumatic brain injury or the acquired brain injury compromise the ability to cope with the stress of PTSD. So when you have both, so when you have, yes, I have this client, he has an acquired brain injury, can be traumatic or not, doesn't matter, but those studies, as I said, use more the people with traumatic brain injuries. Basically, it's a bad mix. I mean, because the symptoms of the acquired brain injury negatively impact, it compromises the ability to cope with the stress of PTSD. So, for example, you have somebody with a lot of disinhibition or apathy, difficulty with executive control, poor insight. It's going to make it so much harder for them to realize what's going on when the actual traumatic memories come back or they're re-experiencing. It's going to be much more easy to go to the strategies to deal with the PTSD, like Dr. Todd was saying, like the avoidance and not realize that there would be other ways. So it complicates that. And in turn, also PTSD compromises the ability to navigate the cognitive and the other manifestations of the acquired brain injuries. So something very important to keep in mind for you as well is that there's a lot of symptoms that are common between people with acquired brain injury and people with PTSD. So there's symptoms that are very specific to PTSD. So the flashbacks, of course, like any re-experiencing of the traumatic memory is unique to the PTSD, obviously. But imagine you're in a car accident, you're re-experiencing the car accident. So that would be a symptoms of, it might become a symptoms of PTSD develop. So the re-experiencing of the car accident all the time, it's not because of the head trauma that it's happening. It would be because of, we would suspect there's PTSD there if it's more than a month that the accident happened. The avoidance, the hypervigilance, like Michele was saying, the nightmares, this is another way of re-experiencing, and the emotional numbness tend to be specific. So if you see that, if you have clients who report that to you, you can suspect, okay, there's something going on that's above and beyond the ABI. On the other hand, the symptoms from this research is typically for the TBI, but will have the TBI will have more create more headaches. We don't really see headaches in PTSD. Dizziness, vision disruption, sensitivity to light and sound, nausea. We'll see that more, and this would be more specific to the head trauma. What is common, and that's most important, because for you, when you see that, you will have like, okay, maybe, so the person reports fatigue, irritability, or you see irritability, cognitive deficits, insomnia, depression, anxiety. Those are common to both. So you'll have specific symptoms that are common. So fatigue can be attributed to the ABI or irritability, but it might not be because of the ABI actually. So you would know if you treat, for example, the person, okay, it looks like it's PTSD, sent to the clinician to provide, to determine the diagnosis, treat the PTSD. you'll see an improvement in the fatigue and irritability group that was related to PTSD, for example. So this is just to highlight that you have the head injury, the PTSD, and also the interaction with the depression. Basically, this slide just say that the same thing a bit as I was talking about. So that both you'll often see that you'll have somebody with PTSD, depression, and the acquired brain injury or the traumatic brain injury. And again, there are like symptoms that are common to the three diagnoses. And there are symptoms that are more specific to each diagnosis. And the lower part of the slide just highlight that actually with this research, they were able to identify the areas of the brain that are more responsible for the depression, which is like the temporal cortex, that are more responsible with PTSD, which is the uncinate nucleus. We're not going to go into detail. And the TBI is more the cerebellum brainstem, and then the areas common to the three diagnoses would be the hippocampus, so the memory area, the central white matter, so they are all the connections that connects the different areas of the brain, cingulate cortex, which is the processing of emotional content, the orbitofrontal cortex, initiation, impulsivity, and the amygdala, which is the area, the nucleus that's responsible for the fear response. So those are common to the three, the depression, PTSD, and TBI. Complicating factors for you guys to know. So the more severe the head trauma, the more likely one is to develop PTSD. So this slide just highlights for you that when you have a very severe, I'm sure it's true for strokes as well, if there is PTSD, when you have a more severe accident, you'll have also more likelihood of developing PTSD. So for the traumatic brain injury, what we see is if you have loss of consciousness or altered mental status. So this is in, so I'm just going to say it. What you see here in red is somebody who had some head trauma, but no injury, nothing else. The likelihood of developing PTSD is 9%. And here you have your 5% here. See my, you don't see my, the 5% on top is when there's loss of consciousness. So one of the most severe head trauma, 44% of people have developed PTSD. And here is just to highlight that, and this was a study with veterans, military veterans from the war, the Iraq and Afghanistan war. So what you see here is just to highlight that, and I'm sure it was going to ring a bell for you guys. It's like head trauma rarely comes alone. So you'll have your people, like your clients. Yes, they have the head trauma, but they also have chronic pain. They also have other psychiatric conditions like PTSD, depression. So the vast majority don't have just one diagnosis, like Dr. Todd was saying earlier, with PTSD is true as well for the acquired brain injury. Just to continue with what we're saying, this is something to keep in mind for you guys, to keep in mind who your client is, because the pre-existing conditions before the acquired brain injury will impact a lot the adjustment of your clients to their new condition. So, a variety of parameters relate to ABI mechanism tend to play a role in predicting the outcome. So, for example, if there's a, it's very similar to what Dr. Todd was telling us. So basically, the family functioning, is it like a healthy family? Is it dysfunctional? Will impact how the person respond to if we think about the stroke, to the stroke, how they will adjust, how they will recover. So those factors matter, like were there any pre-existing psychiatric conditions? Was there any lower intellectual functioning that existed before? So what was the education background of the person before their ABI? It will impact for sure the way they recover, as well as all the sequela. So when you think of a stroke, you can have such an array. It depends on the localization, as we discussed. It depends on how massive the stroke was. So of course, how massive the stroke was will impact, but also if there's physical deficit resulting from the stroke, if there's emotional behavioral deficit resulting from the stroke, if there's PTSD resulting from the stroke, because this is, yes, we see it more with traumatic brain injury because of the condition, like we see PTSD more in those population, but you can imagine with the stroke that a near-death experience, a person feared they were about to die, can definitely, it's definitely a criteria that can lead to PTSD. So the age at injury will matter as well. Just keep in mind for your guys that there's conditions that pre-existed that will impact their functioning as you see them today. So one person will not be equal to another as a result, and their current support as well. And also, this is just to highlight that you obviously need to adjust your intervention to meet the needs of your clients have, which involve helping them with the ABI symptoms. But as you could probably give a talk to us about, it's like all the other things that you do, addressing, like hopefully after today you will feel a little better, helping them if they have trauma responses. But there's also their ADLs, the family involvement, the quality of life, are they too socially isolated? So all this helping them compensate for their cognitive deficits, all this is important when you treat when you take care of your clients. So now we're going to switch a bit to talk about the treatment that are specific for combined ABI and PTSD. So we do have research on that. So is it the same? Do we do the same treatment? So basically, Dr. Todd talked to us about like the treatments that we do with people who have PTSD. So is it the same when we have PTSD and an ABI? Pretty much it is. So first of all, before we talk about the treatment that works, how do we identify you guys? Because often you're going to be the first liners. Like sometimes I bet they don't even, I don't know if they have family doctors, maybe because of their condition, they have a medical team, which is good if they do. Do they all have medical teams typically, or not necessarily? Yes and no. Yeah, I'm not surprised. So sometimes you'll be the first set of eyes, the people who know them the most, who interact with them the most, who see them in their environment. So you'll be the ones who have to kind of scratch your head, is what is going on? Is there something more than the acquired brain injury going on here? So just to keep in mind that like it's super excellent that you're reaching out to identify if there is some PTSD, and to understand the link between ABI and PTSD, because you do need to find ways to identify PTSD. And for you, your role will be more to be the first one to alert. Is there PTSD going on? Could we have this person assessed, please? Try to link them and connect them with some psychologist, a psychiatrist, a team, clinical team that can provide the assessment. But you'll be the first one to, hey, there might be something going on here. And if you don't identify PTSD, sometimes your experience with your clients might be that it doesn't go anywhere. They're not getting better. They're not like some things going on that's above and beyond. I don't understand what's going on. They're more difficult. It's not likely to get better without treatment, like Dr. Todd was saying. And it can exacerbate, as we said. So there are actual guidelines. It comes from Veterans Affairs in the US, but it's very good. The clinical practice guideline for the management of post-acute mild traumatic brain injury recommend to set expectation of recovery. So once it's identified, to encourage them basically, and to refer them to treatment for any comorbid condition. So ideally, it might not always be possible. So referring them to treatment is important. I have a video for you here. So I have to do, just Martin showed me.
There's been a lot of emphasis on post-traumatic stress disorder, PTSD, especially over the last years with increased military activity and wounded warriors. But PTSD has been around for a long time, and it's a series of symptoms, real symptoms that are related to exposure to a very traumatic event and your reaction later on. It's one of many factors that affect behavior, and you really have to understand that. A lot of times I'll get a call that somebody's having a behavior problem, and the assumption is that some obvious issue is causing that, such as this person had a blast injury, they were in Iraq, or this person had a brain injury. And so the assumption is that all the behavioral challenges are related to that. But when we take a look at a person, we really have to take a look at the whole person. We have to take a look at the constellation of their experiences, their life history, their presumptions and understandings to address this. So a lot of times these issues may be related to their exposure to a traumatic event as compared to their traumatic brain injury. And so it's important to differentiate that. I worked with somebody a number of years ago who had a brain injury, and he was coming out of early rehab. And it was his first day out of bed, and the physical therapist was getting him into his chair, and he was very excited about that. He was getting back on his feet. And so he sat in the chair and he was all smiles. And she was all smiles, and she leaned over to put the seatbelt on so he wouldn't fall out of the chair. And as soon as she did that, he punched her in the face and knocked her out. And the issue was, oh my goodness, why did this man do this? What in his brain injury caused him to do this? Well, the facility hadn't done a lot of history on this gentleman, and it turned out that 20 years earlier, he was a prisoner of war in the Vietnam conflict. And he was kept in underground tunnels in North Vietnam for 3 years tied to a chair. So this had much less to do with his brain injury than this gentleman was having a flashback to a very traumatic event in his life. We have to understand that the issues of depression, the issues of anger, the issues of frustration, and all those things can be a function of many factors. And so PTSD is one of those that we have to look at.
So this is just to highlight that sometimes you might see something very odd in the behavior, and it's like, okay, something's going on. It's not the ABI per se. And that's a good example of that. So how to identify PTSD symptoms and have kind of, what's going on? Your relationship will be tremendously important. If you have a good relationship, it's much easier, obviously, to ask questions, to observe, to know if the person is different in certain circumstances. And it will be important for you to convey once you suspect something that there's some real symptom that are happening, but not everything might be related to their ABI, for one thing. You know, there might be something else going on. That treatment of PTSD, if we suspect, may significantly help them. And that the symptoms of the conditions may overlap. It's true for if you see depression as well, but we're talking about PTSD today. And that PTSD can help them address many symptoms that may exacerbate their cognitive difficulties. So people will have a lot of cognitive difficulties, but the PTSD will make it worse. So when we treat the PTSD, well, sometimes it gives hope that actually you'll have less symptoms and even less cognitive difficulties. And it makes sense if you think somebody's hypervigilant with PTSD and always watching their environment. Well, they don't have a lot of reserve less to pay attention to, you know, their grocery list or cooking, or they might be too preoccupied. It takes their mental, half of their mental energy. So imagine if you treat that, then there's more resources left for the rest of their life, of their activities. So, and the residual cognitive difficulties are not necessarily addressed in PTSD treatment, but we can continue to work on that even after the PTSD treatment. So I have a little exercise for you guys. What questions could you ask your clients if you suspect they might have symptoms of PTSD? So now you know more than at 9 o'clock this morning about PTSD. So can you think of like questions that you can ask, like you're with them and you know, you see something, and what could help you confirm your suspicions? So I was thinking of taking 5 minutes to maybe talk with your partner beside you, and then we'll discuss all together. So think of, and just a suggestion, discussing, I don't know if you've heard of closed versus open questions. So try to use open questions. So the question that gives you not just a yes or no in your practice. So it's not bad to have a yes or no answer for some questions, but if you want to get more information, you want to use strategies like, so we call it open questions. So what kind of thoughts do you have? Instead of, do you have bad thoughts? You have bad thoughts? Yes. No. What kind of thoughts do you have will give you more than, so think of phrasing your question. And we can talk more about that if you need support with that. So I give you 5 minutes. All right. So anybody want to share what they came up with? Can help you determine if there might be some PTSD going on.
I wrote a bunch of questions, but I copied you. I said, what kind of thoughts do you have? What kind of activity or leisure do you do on a weekly basis? How would you rate your sleep? How often have you gone out this week? How would you describe your mood? How would you feel? Do you feel supported by your family and friends? And what social or no, what supports do you, social supports do you, or organizations are you affiliated with?
And which of those questions would help you know if there's PTSD or not?
I think all of them.
Oh yeah? So
I would get to know, I would get them talking and know a bit more.
would you want to know if they were submitted to a traumatic event?
Probably, yeah. Yeah.
Yes. And if they re-experience
Oh, okay.
right? Right.
I thought I would know that already, but
True. That's where I thought you were, your question. So for your questions, it's like once you know there was a traumatic event and once you know there's some re-experiencing, then you ask those questions.
Yeah.
So basically what kind of symptoms
yeah,
they have, right? Okay. Yeah.
sorry.
No, that's awesome. Thank you for sharing. Well, that's why we're practicing. Yes.
We have an individual who struggles with using his wheelchair.
Okay.
He uses his wheelchair. So we would ask, how does the wheelchair make you feel? 9 times out of 10, I don't need it. Makes me feel like an invalid. I can walk.
Mm. Low inside. Yeah.
Sometimes he will spend the day in bed if he sees that wheelchair.
Okay.
Even if he sees it, he will get very upset, very agitated, throw things. We have to use our safety gear so that we're not in arm's reach or throw.
That's an awesome example. So now what we want to know that would help us understand what's going on with this client is what is the wheelchair to him? So what is it triggering? So clearly the wheelchair is a trigger of distress, right? So you see the trigger, you see the distress. What's going on? So what you want to know that will help you know, is it PTSD or is it something else? Is to try to see, is the wheelchair reminding him of a traumatic event? Or is the wheelchair reminding him that he's handicapped and he hates it?
I think like a little bit of both, because he needs the wheelchair because he was in a motor vehicle collision.
Okay.
His athletic range.
Excellent. So what you want to know now is like when you see the wheelchair, do you see the accident again? Does it make you think, and then you hate it because it just makes you think of the accident and you try with all your energy to push away those memories? If you have that answer from him, you know there's might be something that is more like PTSD. The wheelchair represents the car accident. If he tells you, no, I don't really have that. What I have is like, I hate myself when I sit in the wheelchair. You might have both, like obviously, but both, if you have the re-experiencing, then you suspect the PTSD. If you have, I hate myself, I don't want this wheelchair, I don't need it, but there's no re-experiencing, then there's something else at play.
I think what also happens too is that when he wasn't with Pathways at another facility, they would just kind of put him in his chair regardless if he didn't want to go into the chair.
So it's aversive.
Yeah, so as soon as he sees the chair, he loses that trust with everybody that they're just gonna throw him in his chair and now he's gonna have to sit in the chair all day.
Right.
Do kind of thing.
Right.
So I think it's a little bit of PTSD of that too, of like, I want the control of not just somebody putting me in the chair. I want to be able to say, I want to be in the chair, or I don't want to be in the chair.
Mm-hmm. So see, that would not qualify for PTSD. Then it is important to discuss that. That certainly qualify for a very aversive experience and powerlessness that he experienced in the previous place. And so it became aversive. The chair is associated with something very negative, like being forced to sit, on it, but not with the traumatic event per se. So when you have when you suspect PTSD, you absolutely need to have a traumatic event. There is one, but not just a traumatic event, the re-experiencing of it. This is what's unique to PTSD. Yeah.
On that instance then can, so like if they landed in like a care home, that can that then also, like, can that be considered PTSD if they then through adversity because of?
That would qualify for extremely distressing and disrespectful and event that hurt the person tremendously, but that would not qualify for a traumatic event per se, according to our DSM criteria.
Okay.
Michele, do you want to add anything? No, that's okay. So absolutely, like, so we really want to discriminate what is PTSD and what is other dramatic events. But we don't want to dismiss the dramatic events. This, what you're describing is very traumatic. It's very, we can say it's traumatic, but it's not PTSD. And it's important because if you send somebody for PTSD treatment and they don't have PTSD, it will do nothing for them. Like the PTSD treatment work when we have the re-experiencing of the traumatic event that the person is trying to push away as much as they can, which is why they avoid and why they're hypervigilant. And if you don't have the re-experiencing, we don't want to treat for PTSD. We want to treat for the distress. We want to acknowledge, validate. We want to stop doing the aversive thing because it's so hurtful for them. We want to tell them how distressing it is, but it's still not PTSD. PTSD is very specific to those specific type of traumas that need to feel re-experienced. So also don't forget, so the car accident, I'm sure was traumatic, but you remember there's about 20% or so who develop PTSD. So not because you had a traumatic event that you have PTSD. So a lot of people, the majority, will recover from a traumatic event. They can have maybe the symptoms at first, and then it goes away if there's not all the array of symptoms that maintains the PTSD. So does it help? Yeah. So the type of question first, yes, is there a trauma? And then do you re-experience through nightmares? Do you have memories that you want to push away? So be careful as well, because some people, they have the memories of the trauma, but they ruminate. They'll want to think about it. If you want to think about something, it's not PTSD. You might be depression. However, you'll see that more in depression. So if you have somebody who's like, oh, I keep on thinking and I should have done this and I should have said that and I should, usually your PTSD person will at all costs try not to think about it, but it's very intrusive. It keeps on coming back and it distresses them. That's why they avoid everything that makes them think of the trauma. So that's so that would be your first set of questions. Once you establish there's maybe there is a trauma and there seem to be re-experiencing, then you will jump to the questions like what is the effect, if you want to know the effect, but you will also ideally want to refer them for treatment. Yeah, did I see your finger? Yeah, go ahead.
But when asking questions about, telling the clients or people suffering from PTSD, asking questions about, telling about the experience is not something like a re-traumatizing the person, because that we're pushing the person to tell you to remember bad things.
So you're asking, is it re-traumatizing them?
Yeah. When for example, they don't want to talk about, some people may answer, I don't want to cry, or I don't want to talk about this.
Mm-hmm.
We keep asking questions.
Mm-hmm. Mm-hmm.
Is there any risk?
That's a very excellent question. And so the way you can so think of it as they're already re-experiencing if they have PTSD. So you don't necessarily ask them to tell you exactly the content of what they're experiencing, but you can ask questions like, is it coming back to you constantly? The memories of, when you had your stroke and you almost died and the ambulance came, is it like disturbing you? Like, are these memories coming back to you? And they'll tell you because if it's happening, they won't have a problem telling you. That won't be re-traumatizing. This is their experience, you know, but they don't usually, like, well, I work with the war veterans, and they really don't like to talk about the event, but they'll tell you, oh yeah, I think about it all the time. So they're not bothered by telling you it's coming back to me all the time, but they will be bothered if you say, tell me all about what happened that day. Then that they don't like. Yeah, it's like, oh, I saw this girl, she was shot, and they don't like to say that. But you can say, it's like, what happened to you when you were in Afghanistan? Like, is it constantly bothering you? You know, do you have nightmares of it? Like, is it similar nightmares? Like, is it triggered? Like, do you think of it when you see something on TV? Like, and then you'll know more, and they won't be bothered by that. But the treatment is something else. When they actually enter treatment, then they will have to retell the traumatic event, but don't necessarily say that. Leave it for the clinician. So the treatment effectiveness, just so you know, there's research that show that if you treat PTSD with your guys who had the strokes or ABIs, there's not that much research, but it seems to be working just as well, as long as they can remember. If there's complete amnesia, no ability to remember anything, then harder. But no matter the severity, it's gonna work. There is some specific treatment for that treat both PTSD and cognitive training. It's called CogSmart. That's specifically more for veterans. And treatment planning, if there's cognitive deficit that gets in the way, we do protocol consistent. I put that slide because I think it might be helpful for you guys when you work with your patients too. So those are things that you can use, strategies for them. Not only we use them if we provide the PTSD treatment with people who have cognitive disabilities or difficulties, but it's good for anybody with cognitive deficits. Different strategies or external memory aids, teach back methods. So if you want somebody to remember their memory problems, for example, like ask them to repeat it to you so they'll memorize better. Include other people in sessions, things like that. So medication, we don't know that much, but basically it's the same if you have PTSD with or without an ABI. And this is a book that I put there that you might find that could be interesting for your team or for families. And that's it. Now, turn the table to Dr. Bolton.
So when you recognize that the trauma response may be showing up in treatment, what are some things that we can do to help respond? How do we recognize, and what are some things we can do to help the client ground or get to their optimal arousal level? And we're going to talk about a couple of different things here. First, I want to talk a little bit about trauma-informed care. And I think that what I'm hearing for both the last couple of questions is really speaking to a trauma-informed lens, right? So it's important for everybody here to know that you are essentially gatekeepers in terms of how people are going to experience their story. And yes, sometimes we have, folks who it might be really hard for them to disclose their story. And sometimes we have the opposite effect as well, right? Where clients come in and this might be their first safe relationship or space or therapeutic interaction. So they might just feel like they need to spill everything really quickly. Has anybody ever had that before? Okay. So it's really important to be able to recognize the difficulty that clients can have with regards to the impact of their trauma story. And how do we put some frames on it to make sure that we are being compassionate, validating, understanding, but also that we're doing this in a safe way, right? So you guys are the gatekeepers of how that unfolds and also kind of really the protectors of safety. So for clients who, depending on the nature of the clinical interaction, when clients have kind of wanted to spill everything, how do you react?
Non-judgmental.
Okay. Calm, non-judgmental, fantastic.
Validating the feelings.
Yes, 100%. Right? Sometimes it's helpful to, depending on the nature of the clinical interaction, like if I'm doing an intake, I might just offer up some parameters ahead of time in terms of, I may ask how the trauma is impacting you, or some things that you might be experiencing in result of having gone through this traumatic event. But I may hold off on asking you to tell your story in details, because that we want to make sure we're doing that in a safe way, in a way that's going to protect you, and also give your story the space that it needs, in a process that's going to be really contained, right? So back to your point, like, I don't want to tell my story because I'm going to get upset and start to cry, right? Well, let's look at that together in terms of, let's be the gatekeeper and do this in a safe way. So everybody here has a responsibility to help safeguard the client's trauma story. Any thoughts on that? Part of that is being able to recognize when a trauma response is coming up, and if it is becoming overwhelming, and we're going to talk about hyperarousal and hypoarousal, but if it's becoming too much, what can we do to help pause for now, to make sure that safety is there, right? So if a client is becoming overwhelmed, and we're going to talk about like what that looks like, how do we just gently pause in a way that's validating and understanding and kind and respectful, but also just making sure that the client is really, really aware of the reason why we need to do this, right? So these are some conversations that I like to have early on with folks, just so that they know, like, if I'm interrupting them, it's not because what they're saying is not important, it's just that we need more space, and we need to create that space and on purpose to be able to have those conversations in a really strategic way. Any thoughts on that? Anything to add? Jump in at any time, guys. Some of the things that we might notice from a trauma response, and we've been talking about this, but like any flood of emotions, or sweating, or flinching, or dissociation, becoming disconnected from the present moment, which we're going to watch a quick video on that. Inability to respond, or to respond to instructions. These are all things that can really come into play. When we talk about trauma-informed, put it all up there. When we talked about trauma-informed care, we're talking about all the things that were mentioned earlier. And there was a couple of really great examples before that really segue into this nicely. So understanding the person as a whole, right? The person is not compartmentalized by their mental health or potential substance use, or there's no compartmentalization, right? It's the whole person and their lived experience between, has their PTSD symptoms of incorporated, escapism through drugs and alcohol. How does that fit in? How do we understand the person as a whole person? How do we understand the cultural, historical, gender, any identity facets that also may be contributing to their experience? And then how do we have that trauma awareness, which is what we're doing today, which is fantastic, paired with creating that sense of safety and trustworthiness and that mutual respect and dignity, and looking at things from a really protective viewpoint. What is this person's strengths? What are their resiliencies? Like, I am always in awe of people who've experienced like traumas and just the degree of resiliency that they have to go on. Like, it's really remarkable to see. So looking at things from a strength-based approach. And then back to your point, which really stood about me with the individual who was forced to go into a wheelchair. If we're looking at things from a trauma-informed care, we want to facilitate choice, collaboration, autonomy. We want the connection, and we want the clients to be really in charge of their health. Like, this is their decision, it's not ours.
And
right?
That's what we're doing, working with them.
Yeah.
Pathways, which is asking if he wants to use his chair, or if he wants to sit in another chair, and obviously he wants to fix the other chair, but I'm just allowing him to know that we're going to give him choice. He's never going to have to force into that chair whatsoever.
I have goosebumps. That is amazing. You guys are living examples of like how a program that is a trauma-informed care, that's trauma-informed program. Like that's doing it right. That's providing him with corrective action that like, this is what it should look like in terms of therapeutic interaction.
Sometimes he does actually choose a chair, like if he actually wants to go out into the community, like he's excited for something, he will say, yes, get a chair.
Yeah.
Like, I mean, he doesn't like it, but he will sometimes now make that choice to choose a chair so he can't go out. But when we first was working with him, it was like, absolutely not, like I would rather stay in bed and not leave forever.
Absolutely. And I mean, think of a time where somebody told you what to do. Has that ever gone well? Not for me. I personally don't like it. Like it's really a sign of respect and just dignity to be able to be provided with that choice and collaboration. And it really does help to harness that sense of safety and that therapeutic alliance, right? Which is integral to trauma-informed care. What this looks like in terms of at an organizational or a program level is, if, do your staff have basic understanding of what trauma-informed care is, trauma awareness, the effects of trauma, things like today, conversations like today, in terms of safety and trustworthiness, even being able to walk through waiting rooms, get a sense of your environment, get a sense of what's happening. Do your therapy rooms, like, can you hear people talking, or are they confidential? Like those things make a difference when it comes to creating that space where people are going to feel more comfortable to be able to do the work. Any choice, collaboration, and connection, again, like what are the options of care also for staff in terms of what you guys can offer for clients? Like, is it, one option or one size fits all, or are there a couple of different things? And like, what does that look like in terms of service delivery? And then this was taken from a Center of Women's Excellence, but basically like as part of the process within the program, do you talk or focus on protective factors, strengths, resiliency? Like how does that play into the nature of your work? Any thoughts? Any thoughts on this piece? No? Okay. So we're gonna do twofold. We're gonna talk a little bit about, if a client may not be in therapy, but you're noticing a trauma reaction, what are some robust ways that we can, robust and accessible skills or tips that we can do to help ground the person or bring them in terms of their ability to control, have an increased sense of control. And there's a number of different ways in. So we're going to take a couple of slides to talk about what are some of those accessible tools that you guys can try on to see, like in terms of if you're noticing the clients are becoming completely overwhelmed or flooded or hypo-aroused in terms of that disconnect or dissociation. We're just going to watch a 5-minute video on grounding techniques for PTSD using a variety of tools.
One of the most common symptoms of post-traumatic stress disorder, or PTSD, is dissociation. When we dissociate, we lose awareness of our current surroundings. In one type of dissociation, known as a flashback, we feel as though we are actually back in the past and going through a trauma again. We have the same feelings as we had at the time of the event, including feeling afraid and in danger. These feelings can last even after the flashback is over. One way to help ourselves manage these difficult experiences is to use grounding techniques. These are things we can do to remind ourselves that we are here now, we are safe, and the trauma is over and in the past. Many grounding techniques use our senses of touch, taste, hearing, sight, and especially smell to move our attention to where we are now. This is because our senses act powerfully to show our brain and body what we are experiencing in this moment. So here are some things to try when you need to ground yourself. 1. Connect to the present. Tell yourself the day and the date, such as today is Friday the 24th of April 2020. I am in my home in London. Look at a happy photo of yourself and say, I am safe in this photo. I am now 50 years old and I am safe right now. 2. Smell. Smell can be very powerful in bringing you back to the present. Find a strong but pleasant smell that you can carry around with you, like aftershave, perfume, or an aromatherapy oil. If you feel overwhelmed by intrusive thoughts or feelings, or experiencing a flashback, hold the item to your nose and inhale slowly and deeply. Focus on the smell and how it makes you feel. 3. Focus on what's around you. Concentrate on something in your environment. Colours, shapes, textures, the feeling of the arms of a chair, the titles of books on a shelf, or pictures on a wall. Try noticing 5 things that you can see, 4 things you can hear, 3 things you can touch, 2 things you can smell, 1 thing you can taste. 4. Develop a grounding phrase. This is a few words or a tune which is a reminder that you are surviving in the present. Phrases can range from a brief, I am okay, to lengthy statements like, I am surviving and I am doing my best. 5. Visualize a grounding image. Rehearse a soothing image using your mind's eye, which helps you to feel in control and safe. A place you've been to, or a place you can imagine. 6. Find a grounding object. Find a comforting object you can keep with you in a psychological first aid kit. Focus on this object when you feel overwhelmed. Pay attention to how it feels and looks or smells. This could be something like a stress ball, pebbles, essential oils, or a photo of a loved one. 7. Engage your mind. Do something that helps your mind to stay focused on the present. For example, try reciting something you know, like a verse or a prayer. You could say out loud the directions to somewhere nearby, like a supermarket, as if you were explaining them to a friend. Some people find it helpful to count backwards. Start with a random 3-digit number, for example, 158, and then count down in sevens, for example, 158, 151, 144, and so on. Finally, practice your grounding techniques once or twice a day so that they feel familiar and it is easier to do them when you need them.
So basically, we're going to talk a little bit about, the different mechanisms within those types of techniques. But basically, very simply put, we want to orient the client back into the present moment in whatever way that we possibly can. And depending on the nature of your clinical work or your clinical interactions with the client, a lot of these discussions are going to be ahead of time, like not when the client is in distress, we're going to be like, okay, let's count backwards. It's going to be a conversation before it gets to that point in terms of, let's try some things on and see what fits. And then when I notice, and having that collaborative plan, like if I notice what, and really understanding what their cues are, So that when that occurs, you've already have that plan together, that collaborative plan together to be able to then employ that, and then it doesn't come out of left field. And it's really interesting too what people are drawn to when it comes to different techniques. So the way it works is there's different ways in terms of like how this processing occurs. There are just two different ways of processing and making sense of stimuli, right? So in top-down processing, we use our background knowledge, our experiences, our expectations to help our interpretations of what we see. So our cognitions can influence our emotions and behaviors, right? So, you know, for example, like when I'm working with individuals who've experienced, you know, the threat of landmines, there's a certain type of ground or soil or setting that then becomes emblematic of that fear response, right? So it's using that background knowledge and experiences is kind of like shaping their threat in terms of their response to their fear response in terms of threats. We're going to go into it a little bit more detail. And then in terms of bottom-up processing, it allows the stimulus to shape our perception without any preconceived notions. And that's when our emotions and our sensory input kind of influence that response. So based on that, the grounding ones, there's a number of ones that were employed that kind of demonstrate the top down and the bottom up. So for top down, using our cognitions to influence, like we counting backwards and from 100 in series of 3, the mental math piece is actually incredibly difficult to do. And this seems to be, in my experience, to be a very powerful one. As we've discussed in terms of the brain, like what it does is when individuals are in that heightened state of arousal, their ability to have that rational thought, their prefrontal cortex is shutting down. So anything that we can do to then bring the awareness back to the prefrontal cortex gives us increased sense of control, attention, and our ability to kind of then make decisions. So I want you to turn to your partner, and I want you to I just want you to go back and forth in terms of series of 3s. I want you to count down from 100 in series of 3s. Just try it out for me. Guys, I'll bring you back. What did you notice?
Oh, you telling me.
Okay, bingo. The only thing you're focusing on is the number, right? Was anybody like experiencing any like strong emotion while you're doing that, or was your focus on the number? Right? It was stressful, 100%. Mental math is like my nightmare, but it works because it breaks the emotion, it breaks the overwhelm in the moment. And clients actually quite like this because it's also, in my experience, a very non-invasive way of doing this. So like I've had clients who dissociate in public, and their partner will then ask, okay, 100. And they can do that discreetly in terms of helping bring back without the outside world really being aware of what's happening, right? Some of the other things like are a little bit like include like, you know, throwing the ball or those kinds of things, but this one tends to be really accessible, and you can have other people supporting that process when they notice these things coming up. The other one is naming objects in the room in detail. A lot of my clients said there's one particular painting where they know every single pixel of that painting. Name the provinces or the capitals, or discuss your weekend plans and goals, right? So anything that brings your focus to your prefrontal cortex brings you into the moment, okay? There's also bottom-up grounding processes, right? And these are the ones that are going to focus on our sensory experience, right? So focusing on breath work, changing your facial expression, changing your physical sensations in terms of walking, shifting positions. One that I like as well, and again, this is just my personal, my clinical opinion, but anything that'll also change, like if somebody's in extreme distress, something that changes the temperature as well. So often clients will like to, well, they won't like to, but they find it really effective to like, you know, hold an ice cube. Because if you're holding an ice cube, you're changing your physiology, and it's really hard to stay in an emotional state of mind because it's a different sensation. Cold showers, another one. Not pleasant, but it breaks It breaks the emotion because it brings you to a different part of your brain. Anik, anything to add in terms of the brain aspect? Okay. Any thoughts on that? Has anybody tried this before with clients?
And I was just gonna say that, I think it's worthwhile to talk about, too, because some of the work we do, you go into a situation where you've never met the person, right?
Yes.
And I think back to a time when I went in, person was clearly in a full-on panic attack. I never met them. They had fallen and were panicking in the front entrance way, like there was nothing founded. So I took my fur lined mittens and got them to touch that.
Perfect.
And breathe with me, and then we started counting that.
Yes.
Just kind of look at what you've got if you're going into an environment unknown to you.
Absolutely.
What have I got?
Yes. And also like at a program level too, looking at like, is there any like psychological first aids kits that clients can like create where it's like, for me, these are the tools that work. Like, so then if you have even new staff that are not aware, it's like, okay, well, I need this box, and they can help encourage their own self-practice of some of these things could be helpful, right? And I want you to keep that thought about the hyperarousal piece, because I think that's key. Okay. For breath work, again, inhalations, they activate the excitatory pathways. That's why we see like hyperventilating is like that quick breath. Exhalations activate our calming pathways, right? So we want to exhale longer than we inhale for that calming effect, right? So the goal is to slow down and deepen those breaths, right? For the purpose of time, I might not do this activity, but I would encourage folks to take a look at diaphragmatic breathing exercises, because those can be really helpful and acceptable, help the client slow down. And sometimes like having that breath work, be like, okay, can we try that? And that's, one hand on the chest, one hand right above your belly button, and pushing your hand with your belly button, and just making sure that you're taking those long, deep breaths, right? Being able to practice these things as much as you can ahead of time with clients can be helpful. But again, they're just things to try on. So if somebody's in that hyperarousal state, we want to help slow down. Okay. Okay. Any thoughts before me? The goal is to help with the emotion regulation skills, right? So let's bring the client back to the present moment, right? It's really in terms of bringing the client back so that they have the ability to reflect on their inner experience without that sense of overwhelm. So can they feel what they feel? What can they feel? Can they tap into their emotions? Can they feel their emotions? Can they process their emotions within session, but still operating within that therapeutic window? Okay. What I mean by window is there's this idea of window tolerance. Is anybody familiar with this? Awesome. Awesome. So there's this window of tolerance, and everybody's window of tolerance is different based on our childhood experiences, our neurobiology, our like a number of factors. But what this means is that, like, for example, for your client who gets triggered by the wheelchair, if that's a stressful event for him, does that push him outside of his window of tolerance, right? So that window of tolerance is really that optimal level where we can still engage, make decisions, interact without going into a state that's going to be either hyperarousal or hypoarousal. So what I mean by that is that for hyperarousal, your sympathetic nervous system kind of ignites. And that's when we have that fight or flight response, panic, okay? That's when you start to see like any of that like agitation, like any of those cues in terms of being like over-aroused, okay? Conversely, stressful information or stressful situations can also conversely cause hypoarousal. And that's when we dip below, which then that's where we start to see our parasympathetic nervous system kicking in and what was shutting off, right? So that's where we experience dissociation, disconnect, right? Numbness, So we want to make sure that we're helping clients, if we're noticing either of these spikes, we're helping them get back into the middle of that optimum arousal, where their feelings and responses are manageable and do not prevent them from thinking. Okay. I've got a 3-minute clip from an Australian clinical training network of a clinician who's responding to a client who's dissociating within session, where he employs a number of these different skills to try to get her back into her window of tolerance.
So Jess, how did the police interview go? How did that play out?
Well, they came to my house on Tuesday.
Yeah.
And I had my mum with me. And I had to tell them everything.
Yeah, it's hard.
Like, I had to go into so much detail.
Yeah. Hey Jess, just come back to me. Just come back to the room a little bit. Can you just look up at me? What colour eyes do I have? Can you check it out?
I'm like brown.
Brown. Okay, good. Okay, just trying to get you back into the room with me. Okay, so just look around the room. Can you see maybe this painting that's up here? What do you see? Can you tell me what the painting's of?
Beach.
Yeah, a beach.
Sun.
Yeah, cool. Okay. Hey, I want you to do something. I just want you to catch this for me. See if you can catch it. Throw it back to me. Okay, just throw it back to me. That's it. Good. Just throw it back to me. Good, okay. Just see if you can stay here in the room with me, yeah? Hey, and also, listen, catch that one. That's it, okay. So just want you to keep in the room with me a bit. I know sometimes it's a bit stressful and a bit overwhelming, okay? But we're still connected, okay? You're not back there. Okay? How are you feeling? Just stay with me. Yeah? Okay.
Really, it was really hard to talk about.
Yeah.
That stuff.
Yeah, it's completely understandable. These are really, really tough moments, and those sort of conversations with the police sometimes can be very stressful for you, yeah? I get it, yeah. So maybe, how are you feeling now? Where are you at?
Yeah, a bit better.
Yeah? Okay, so maybe just, why don't we keep talking and we can just remember that we're connected, okay, and you're here with me. Yeah. So tell me a little bit more. So your mum came with you to do the statement? Or?
Yeah, so mum was with me.
Yeah.
They came over and there were 2 detectives.
Yeah.
And they just wanted to know everything, and it took like hours.
Yeah.
And
how are you feeling now after you've done it? What's that?
Like, I'm glad it's over and done with. I didn't realise how hard it would be to talk about it here.
Yeah.
For some reason, I was thinking it was all over and done with.
Yeah.
But I'm okay now.
Yeah, well, it's really understandable. It's completely, understandable that sometimes it's difficult to talk, and sometimes you kind of float back to tough times, So why don't we just keep talking? We'll keep talking like this, okay? Yeah.
What did you guys notice about her behavioral cues?
She kept flicking her hair when she was stressed.
She started touching her hair. She started fidgeting with her hands. What was that? She started hugging herself, right? That's a huge cue. When somebody starts self-soothing in that way, or they're becoming small, like that's often a cue that we're starting to lose them a bit. Good. Anything else?
Eye contact.
Avoiding eye contact. Great. What did you notice about his reaction? What did he do to help bring her back?
describe the picture first.
Describe the picture. Yeah,
And look at him.
look at him. Yeah, come back into the room with me, please.
Yeah.
Yeah. Catch the pillow.
And holding a soft object,
Yes. Yes.
comforting.
These are always anchoring her back into the moment, right? So just, you know, just being able to pause just to make sure that her regulation, her emotion regulation was at a place where she wasn't overwhelmed, right? She wasn't becoming dissociative. The other types of interventions that we want to do from a cognitive approach is also this idea of meta thinking, which is thinking about your thinking, or as I like to think about it, taking an aerial view. When we're in the emotion, when we're in the distress, it's hard to remove ourselves in terms of having a little bit more distance from that distress of the moment. So some of the things that we do in treatment is really, how do we become an observer in a non-judgmental way of our own thoughts, of our own experience? Yeah, so being able to take a step back or kind of create that distance again from the distress, right? As human beings, we're very susceptible to making mental shortcuts, to trying to interpret our environment, to interpret the world. And part of that sometimes comes with some cognitive distortions or thinking errors or unhelpful thoughts. And some of the ways that some of the things you might notice in clients is, you know, this idea of like zebra thinking, black and white, right? I'm either perfect or I'm a failure. There's no in between, right? Or elephant thinking, this idea of like really catastrophizing, right? I'll never be able to do anything. I'm always going to feel this way, right? Skunk thinking or stinking thinking, which, thank you, Anik, for that. Emotional reasoning, right? I feel shame, therefore I must have done something. Our emotions are awful predictors of actual objective evidence, right? So sometimes we can feel something without there actually being any proof that that is true. And frog thinking, jumping to conclusions, right? This idea that, you know, A plus B equals E, right? Individuals with PTSD, one of the salient features, as Dr. Todd had described, is, you know, those shifts in cognitions and moods. It changes beliefs about ourselves, about others, about the world, right? So for people with PTSD, some of the traditional ways that it can shift beliefs is, I'm not safe. The world is not safe. I can't keep myself safe. Themes of trust, right? People can't be trusted. Power and control, right? I was powerless, or I should have done something different, right? This idea of being able to have prevented or had some more control is often a fallacy, a belief that comes from the trauma. Intimacy, beliefs about, you know, intimacy and relatedness to other people and feeling connected to other people often gets shifted by virtue of PTSD, right? And self-esteem. All of these ways are ways that we can get stuck in these different beliefs attached to the trauma. And some of these labeling thinking errors are the ways that kind of continue to perpetrate those like stuck points of those beliefs, right? Within cognitive behavioral therapy, we have a phrase: you want to catch it, you want to check it, and you want to change it, right? How often are we encouraged to think about our thinking? Probably not that often, right? Our thoughts become so implicit or so subconscious sometimes that, like, you know, we just, you know, it's very rare to be like, wait, what was the thought that just went through my mind when I felt that pinch in my stomach, right? If you're feeling distressed, wait, what am I telling myself? What's the story I'm telling myself about this? What's the interpretation here? Okay. So the first thing that we always want to kind of look at is like catching the thoughts, right? From a non-judgmental point of view, right? And then checking it. So there's some distancing kind of questions or language that we'd want to do to kind of look at these thoughts from different angles. You know, how often have people had thoughts about like, oh my God, I'm a failure? And then asking folks, would you ever say that to your spouse or your loved one or your kids or your best friend? Because often what we tell ourselves is vastly different than what we would tell somebody we care about. Looking at, is this a helpful way to think about it? Or are there any alternatives? Is this serving me? And then looking at the evidence for the thought, right? So being able to put some of these thoughts on trial. And we do this in a number of different ways within therapy, in terms of how to put these thoughts on trial. Often individuals with PTSD, a lot of the thoughts that kind of come up are the beliefs about, it's my fault, I should have done something different, I'm worthless, I'm unlovable, this is always the way it's going to be. So we want to make sure that we're pulling out some of those things and then really putting them on trial in terms of like looking at the evidence and looking at some of these distancing things to kind of get that sense of cognitive reframing around how these things are impacting. Because as you can imagine, having this thought of I am unlovable could be deeply tied to feelings of shame, disappointment, sadness, anger, all of these things. So it's important to kind of, this is part of the processing for individuals who are in like CBT treatment. And then change with compassion. And the compassion piece is really like a really important ingredient, right? So there's a number of things that we do within therapy to help reframe and change and shift these things as part of the processing of PTSD. Any thoughts on this? I know we're kind of getting towards the end of the day. Any thoughts on this? No? Okay. You might be supporting somebody who's in therapy within at your organization. So I just wanted to show you what some of the tools could look like when we're talking about catch it, check it, change it. We're looking at some of the ADC thought records, and this could look different in different like arms of processing treatments, whether it's like cognitive processing treatment or CBT more generally. But really that's about looking at the activating event or the trauma, and then what are the beliefs that emerged in result of that, and then really putting it on trial in terms of looking at the consequences in terms of behaviors and emotions, right? If I'm feeling embarrassed, I may want to avoid certain things, right? So looking at how all these things, the thoughts, the emotions, and the behaviors are all interconnected as a reaction to this activating event, and then taking a look at, through time, really putting these things under the microscope to see like whether there's alternatives and whether there's some cognitive restructuring that needs to occur. So this is one tool that typically gets employed. Within other forms of CBT treatment, it's also not uncommon to see some of the avoidance and the safety behaviors, as Dr. Todd had mentioned earlier, challenged by these behavioral experiments, right? So these are really graded, gradual, systematic, contained exposures that clients will do within CBT treatment that help to provide that corrective action. So tolerating that distress to provide that corrective action to things that they are avoiding due to the nature of the trauma, right? So again, for the client who may be exposed to landmines, that might be it. Then part of this exposure hierarchy would be like, okay, can we walk on grass in Ottawa, right? And being able to then kind of have those different gradient levels of exposure to get that corrective action that not all stimuli like that is going to be indicative of that degree of risk as was when exposed to landmines. Does that make sense? Okay. Again, speaking to the hypoactive, like, when people are experiencing those periods of low, or they have concurrent depression, that's when we also want to encourage folks to get active, right? So, avoiding symptoms can really, to Dr. Gosselin's point, really rob you of a lot of those really valuable and meaningful activities and connections. So how do we get people back? How do we get them back engaged in creating those meaningful and active goals? And one of the ways that we do that is through behavioral activation and approach, right? And that starts normally with SMART goals. So we create these very specific, measurable, attainable time-sensitive goals, realistic and time-sensitive goals that we work towards that will also twofold get people back engaged with the world, but then also help increase their sense of mastery and their confidence as they then will that will help with the progress as we create a little bit of a snowball effect. And lastly, this is another like an example of an active plan in terms of, you know, recognizing the avoidance symptoms and the plan to get active using these different types of tools. So these are some of the things. This is not exhaustive. There's a lot of different tools that you'd find within EMDR, CPT, and PE. But these are some of the tools that your clients, if they're engaged in PTSD treatment, may reference. Okay. I'm going to throw it over to Anik for question and answers.
For someone who's low income that has like had a trauma and he has the PTSD, is there somewhere where it's cost effective for them to go if they have very limited income?
Well, if they're in Ottawa, depending where they are, like there's always the University of Ottawa, the Center for Psychological Services and Research, CPSR, which has it's really not expensive. The treatment is given by students, but supervised by experienced psychologists. That's an option. Okay. They avoid lists, obviously, but very good treatments.
OSP.
Oh, OSP, that's right, that's true. Like
So the Neurotrauma Psychotherapy program offers free treatment to individuals who need help with any of the anxiety disorders, depression, PTSD, and individuals with mild TBI would not be excluded from that. So that's
Ontario Psychotherapy?
Ontario Structured Psychotherapy.
And the way that you would refer a client would be on Access MHA. So I'm one of the clinical training leads for Access MHA. Go to accessmha.ca and there's a self-referral form, or anybody in this room can also refer a client, and one of our you know the door to get to OSP for free PTSD treatment as well as anxiety disorders and depression.
I've heard about the CBT, but the EMDR, that's the eye movement.
Yeah, the sensitization.
How does
and the reprogramming. So how does that work?
Does it take the focus away from?
Oh, you mean was the mechanism how it works?
Yeah,
that's we're still scratching our head about how it works. It's very hard to know. We know the research shows with PTSD that it really improves the condition by decreasing symptoms. There's many different hypotheses on the how to, like one that we can consider that seems plausible to me anyways, is that it well, you remember the arousal window?
Yeah.
So it might make by doing something a little distracting, it might make the exposure to the trauma more tolerable.
Yeah.
By giving a little bit of a distance.
Right.
While processing the trauma, because the processing of the trauma is the key in all those evidence-based intervention that we know from research that are effective. Process the trauma. There is a processing of the actual traumatic memories. Yeah, we don't. There's no way around it. It seems.
Can some people get over PTSD on their own without?
Well, some people get over the trauma on their own, as you remember, like you'll have a traumatic exposure, and a lot of people, the symptoms go away by themselves. If they start to have all the pattern that we know maintain the symptoms, it doesn't tend to go away without the treatment because it's self-maintained. If you use avoidance, all kind of avoidance to make sure that you don't think about the traumatic event, it's constantly reinforced, so it doesn't go away on its own. That's our experience. It's extremely resistant to time. We had people with 35 years of PTSD came to the USI clinic. And it was still, it's even worse over time if they have no treatment. Typically, if they have treatment, however, the prognosis is very excellent, very excellent. Yeah, it's a big, very big difference when you get the appropriate treatment.
Yeah, I just wondering what you would ask before in terms of like the re-exposure piece. PTSD treatment, what I'm gonna do is if we can also still do it when people are still at risk of re-exposure, so active police officers undergoing PTSD treatment while they're still at risk of. So I just wanted to yeah.
And you'll see at times that that was a good question too, because you'll have people who come to us, and that might happen with your clients too, who had a trauma a long time ago and we're okay for years, and then something happens and everything is back, and then suddenly they have a full-blown delayed PTSD, we call it re-traumatization. That happens sometimes. Like recently, I had an active military member who had sexual abuse like a while ago, but she's a medical doctor in the military, and what made us have full-blown PTSD symptoms is when she was deployed, and as a medical doctor, she started to collect the experience of sexual traumas from all the members she was responsible for. And she had been able to maintain everything and to be functional. And then when that happened, she became completely not functional. So you'll see that sometimes. It's in the different.
Thank you. Just in response to your question, Dr. Gosselin, Dr. Bolton, Dr. Todd developed this course specifically for us.
Yes.
So we are just very grateful.
Oh, good.
So I really